you very much, and good afternoon, everybody. It's an absolute pleasure to be a part of the CAHO CQE series today, and would like to take you all right into the first session without any ado. One of the main points of differentiation in quality amongst hospitals comes from the infrastructure. So this session one is also based on the infrastructure needs of obstetric centers. Signages on high-risk pregnancies, ICU, HDU, NICU requirements, pediatrician availability of CCTV, all these have a bearing on the patient safety and care. So let's welcome our first speaker, Dr. Manju Puri from LHMC Delhi, Lady Hardinge Medical College, the Director, Professor and former Head of Department of Obstetric and Gynecology, and from New Delhi. She's been the President, National Association of Reproductive and Child Health Delhi, Chairperson of Safe Motherhood Committee of AOGD. She's been awarded the CS Dawn Prize, CL Zaveri Prize, and Srimati Bhagavato Yamuna Singh Prize by the Foxy. Honorable mention, John S. Sierra IJGO Prize Paper Award, Teachers of Teacher Award by Delhi Gynecologist Forum, and the Best Paper Award at the 6th World Congress of RCH. She's delivered Suman Kher Oration and Srimati Leelavati Oration and Abhilasha Oration too. And her field of interest has been quality improvement, high-risk obstetrics, and reproductive endocrinology. She's edited a lot of books on anemia in pregnancy, management of high-risk pregnancy, practical approach, clinical methods in obstetrics and gynecology, and contributed many chapters in these texts. Before handing over the session to you, Dr. Manju, we would like to inform you that Dr. Suvin Shetty would, at the end of your talk, facilitate the question answer session with you for about 5 minutes before we move on. Over to you, Dr. Manju, for an extraordinary session.
Thank you, Ms. Gayathri, for this kind introduction, and thank you, CAHO, for inviting me to deliver a talk here. So I'll be sharing my screen. Yeah, I hope my screen is visible. Yes, sir.
Yes, ma'am. Yes. Yes.
So a very relevant topic for today's conference, and I will be talking on infrastructure needs for obstetric centers. Now, quality of any service is influenced by three things: competencies of service providers, availability of resources, and presence of an enabling environment. Many initiatives have been taken on improving competencies, but activities to improve enabling environment have not received adequate attention. Obstetric centers are special as they cater to pregnant women who are mostly young and healthy, most of them present in emergency and need immediate attention. Hence the importance of a well-planned and organized obstetric centers. When we look at quality healthcare, it is care which is safe, timely, equitable, effective, efficient, and person-centric. We all know that. And it is a focus on the care as experienced by beneficiaries, which becomes more important when we talk about infrastructural arrangements when a beneficiary arrives at an obstetric facility. Now, if we look at the infrastructural needs of an obstetric facility, there are a number of them. The antenatal and postnatal OPDs, the labor areas, labor OTs, nursery, SNCU, NICU, MNCU, milk bank, obstetric HDU, ICU, blood bank and storage unit, high-risk antenatal and postnatal IPDs, the central sterilization department, 24/7 lab, imaging, skill lab, areas for antenatal and postnatal classes. So not all the facilities are going to be present, all the items are going to be present at all facilities. It is dependent upon the level of care which a particular facility is to assigned to provide. So the components of obstetric care, we are going to focus on the labor room today. And so the components of obstetric care would include labor, birthing, recovery, the postnatal or postpartum period, plus the care of the newborn. And the special requirement for high-risk cases would be obstetric HDU, ICU, baby nursery, SNCU, NICU, and MNCU. Now, level of cares have been defined at various facilities across India, and both for the mother as well as for the newborn. And the infrastructure requirements are tailored accordingly. A number of guidelines have been put forth by Government of India and other organizations in the last decade. And that has really actually helped people understand as to how can we improve the infrastructure and our processes so as to provide the best of care to our mothers. What is important in today's time is when we are talking about medicalization of birth is to triage the pregnant women at the entrance into low risk and high risk. Low risk should go into midwifery-led care, whereas high risk should go into obstetrician-led care. And this should happen at all levels, antenatal, intranatal, and postnatal levels. Now, midwives can provide 87% of essential care for women and newborns when they are educated and they are regulated to international standards. And they are actually the most cost-effective healthcare providers for childbearing women. A midwifery unit is a location offering maternity care to low-risk pregnant women in which midwives take primary professional responsibility for care. And these units may be either freestanding or they can be alongside. So I think this is a very important change which we all need to move further and have it as a part of infrastructure. Now, this is the difference between what the labor rooms look like in an obstetrician-led unit and a midwifery-led unit. Now, when we talk about a midwifery-led unit, so these are the units which offer an environment that promotes bio-psycho-social model, meaning thereby that they provide a home-like environment where the mother can freely move around. There is equipment like birthing balls, bag, birth mats, birthing pool, and if possible, an access to outside where the mother can move around in the natural environment and have a natural birth. I think this is what we should look at. Now, labor rooms are fundamental to providing quality intrapartum and immediate postpartum services. They play an important role in reducing maternal and neonatal mortality. So it is essential that labor rooms are structured and organized for high efficiency and high quality service delivery. So if you look at the labor area, it has got a core labor area and support areas. The core labor area can be a conventional labor room or a LDR, that is labor delivery recovery concept room. And the support areas should include reception and the waiting area, the triage area with the patient changing room with attached toilets, a shoe changing room, a changing room for the healthcare providers to move into the area of labor room, then duty rooms with attached toilets, a store, a dirty utility room, a clean utility room, a procedure room, air handling unit, and of course, an area for sterilization. On top of it, there should be an operation theater in close vicinity without, where we can shift the patient without wasting time from the labor room to the OT if we have to do an urgent cesarean section. Now, when we look at the labor care models, the labor rooms can be traditional or conventional, wherein a pregnant woman is admitted at or near full dilatation of cervix and is transferred to a postnatal ward after 2 hours. So her average stay in the labor room is 8 hours, that is 0.3 day. Whereas in contemporary labor room, which is a LDR concept, which is a labor delivery recovery concept, the pregnant woman is admitted to the LDR when she presents in labor. She labors there, she delivers, and then she stays there for 4 hours postpartum. So the average stay of a woman in LDR is 16 hours, and that comes to about 0.67 days. The third concept which is coming up is labor delivery recovery postnatal concept, wherein the pregnant woman comes gets on into a room where she labors, she delivers, and she stays there till the time she's discharged. The aim of all this is that the anxiety of shifting the patient from one area to the other area, as the labor progresses, is very inconvenient, both for the healthcare providers and the woman and her mother and her family. Now, this is what a standard LDR unit looks like. So there are actually beds. So each LDR unit will have 4 labor beds. It would have a central nursing station with a newborn care area, and 2 toilets, 1 toilet and washing room for 2 beds. So that is, there are 2 toilets and 2 washing area. So this is what is the requirement. And this would take approximately 1,000 square feet. When we look at the conventional labor room, there is a labor table because the patient is not going to be here for a longer time. And then you have a newborn corner and you have a nursing station and a toilet. So this is what is a conventional labor room. Now, every facility should have adequate number of labor tables, which are calculated by a formula which is given by the Government of India. So this depends upon the number of deliveries which are happening. And any facility with a delivery rate of more than 100 can have a LDR concept because they need more than 4 labor beds. So we would prefer a LDR concept because it is most convenient for the providers as well as for the beneficiaries. Now, there is a formula for calculating the number of labor beds at any facility. For this, we have the projected labor events in a year multiplied by average length of stay of the woman and then divided by 365 into occupancy rate. So what are projected labor events? It is a number of vaginal births and emergency cesarean sections. The average length of stay is 0.33, as I have already told you, that is 8 hours in conventional labor room, and it is 16 hours or 0.67 days in LDR. And the occupancy rate which is recommended is 75% or 0.75. A small example, a facility which has got 7,200 projected deliveries, in which there are 6,120 normal deliveries and 1,080 cesarean sections. Out of these, 600 are unplanned. So the total LDR events for this facility would be normal deliveries plus emergency cesarean section, that is 6,720. And the number of LDR beds required would be the LDR events multiplied by 0.67 because it is a LDR concept, divided by 365 into 0.75, which is the occupancy rate. This comes to 16 beds and each LDR has 4 beds. So this facility would need 4 LDR complexes. So this is how the conventional layout of labor room should be. So if there should be an entry for everyone and then one entry for the patient right at the beginning. So there should be a reception with adequate waiting area with attached toilets. This from here, the patient moves into the triage, and in the triage, the patient then moves into, after changing, can move into the labor room. Whereas on the other side, we have the staff room, the changing room, and here the staff would change and get into the labor room. So after the entry into this door, we have the conventional labor room with attached toilets, and then there's a nursing station. And at the end, you would have the dirty utility area, the store, and the clean utility area. So this should be the layout so that, people don't crisscross into the labor room. And, it should be a nice flow, comfortable flow. If we look at the, the concept of LDR, we just have an additional doctor's duty room and a procedure room to add to it because this would be for a facility which has got more number of deliveries. So you can have an in-house ultrasound or you can have a procedure room and you have a doctor duty room in addition. Rest all is the same. So it is important that it should be a nice open area with big windows, daylight coming in, and it should not be claustrophobic for the woman. The other important components which are there when we consider the labor room setup is, one is direct access into the triage. So there should be an area where the ambulance can come directly and then the woman can be wheeled in and triaged. So the layout which I showed you, so basically now we would propose that we should have integrated MCH and MLUs, so that we should have one area which is low risk, which is midwifery led, and the second area which is high risk, which is obstetrician led. And we should have the labor rooms as per the requirements for midwifery unit and the obstetrician led unit. The ambience has to be very nice because we know that ambience has a lot to play on the hormones of the mother and how she feels, how comfortable or at ease she feels. Lots of natural light should be there. The lighting and power backup is very essential because there are emergency procedures which have to be done. So we cannot do without power backup. CCTV and security concerns, because these are areas where a patient needs privacy, she needs to deliver with dignity. And, then there are newborn babies. We don't want, there are occasions when the babies are kind of lifted. So, that kind of security measures should be in place. And there should be nice CCTV footage. And then very easy access to operation theatre is what is desirable. Now, looking at the HDU, obstetric HDU, here, if we enter again, there is a waiting area. And then we have a stretcher and a trolley bay. So waiting area is attached to the toilets, and then we move in and we have a doctor's changing room, you have a nurse's changing room, and then again further another door and we move in. And then you have a doctor's duty room, you have nurse's duty room. And further in, when you go, this is the area where you have beds, which are nicely spaced. The details are given in the modules, the guidelines which have been issued by the government. This is the nursing station, and two nice things which are there is one is a general store and one is a equipment store attached direct to the internal area. And then you have a dirty utility area here with the exit, which is other from the entrance. So I think this is the layout which is there for HDU. And if laid out in this way, it can be very, very useful and comfortable. In ICU, rest all stays the same, except that we have a X-ray and an ultrasound room. Two additional things which are there. Rest all is same as what is with obstetric HDU. So to conclude, obstetrics services are special as the pregnancy is a normal physiological process. Our patients are not sick patients, they are not diseased, and the pregnant women are often young and healthy. So it is important that they have that kind of environment in which they are moving in. And the process of labor is arduous. The surrounding environment and the psychological support plays an important role in facilitating delivery and women's experience of care. It is important that all the areas have very good signages, because patients or the family has to move from one area to another area. So it is important that all the areas, the family feels very easy when they come to the facility. The woman's experience in labor determines her health-seeking behavior for herself and her newborn subsequently. Hence, it is important that the mother and the family have a beautiful experience when they visit any obstetric facility. And infrastructure of every obstetric facility must be planned to provide quality care to all pregnant women. Means that is safe, efficient, timely, effective, equitable, evidence-based, and client-centric. So thank you so much for patient hearing.
Thanks a lot, ma'am. It was a wonderful session because you were very practical with your topics, in sense that what kind of a requirement from an infrastructure point of view. And I am sure that the delegates may have taken home the message that is needed to be conveyed.